She went to one of the best sports medicine clinics in the valley, the kind that takes care of professional athletes. She got a cortisone injection into her hip, and the relief was, by her own description, amazing for 2.5 months. Then she went back for a second one. No relief this time. And something else happened that nobody warned her about: full adrenal suppression. Her body's ability to regulate its own stress hormones was so disrupted that it took years to fully recover. And in that window, while her system was suppressed, she had some dry needling done. A tendon ruptured, not because the dry needling caused it, but because the tendon had already been quietly weakened by the steroid. And nobody connected those dots for her. I'm Dr. Tammy Penhollow. I'm a physician specializing in spine and joint care and regenerative medicine. And I work with active adults dealing with knee, shoulder, spine problems who are trying to avoid unnecessary procedures. I want to be direct with you today because what I'm about to say is not what most patients hear in the room where the injection happens. Cortisone is not benign. It is covered by insurance. It is fast. It is familiar, and for a lot of physicians, it's the path of least resistance. But on the list of what it does to your body beyond quieting pain is long, and most of that's never discussed. So let's go through it, because if you're making decisions about your joint health for the long run, you need this information. Let's start with the one that should stop every joint patient in their tracks. Corticosteroids are directly toxic to cartilage cells, chondrotoxic. That's not a fringe opinion. That's documented in the literature. Every tissue you're trying to protect, the cartilage inside your knee, your hip, your shoulder, is damaged by repeated corticosteroid exposure. In a healthy joint, chondrocytes are the cells responsible for maintaining cartilage integrity. Corticosteroids suppress their activity and accelerate their death. So if you have a degenerative joint and you're getting repeated cortisone injections to manage the pain, you may be accelerating the very process you're trying to slow down. The pain is quieter, the joint is getting worse. But that's not a trade most people would knowingly make, but they make it because nobody explains it. It weakens tendons. And this is where my patient's story becomes a pattern, not an exception. Corticosteroids alter the collagen structure of tendons. Tendons are load-bearing structures. They're designed to handle tension. But when their collagen matrix is disrupted by steroid exposure, they lose some of that tensile strength. The tendon does not announce this. It doesn't hurt more. It doesn't look different on an MRI necessarily. It's just more vulnerable. And if you're loading that tendon through daily activity, through rehabilitation, through a procedure like dry needling, without knowing it has been compromised, you're taking on a risk you didn't consent to. Tendon ruptures following corticosteroid injections are documented. They're not rare, and they're almost never connected to the injection in that conversation that follows. Corticosteroids are one of the most well-established causes of secondary osteoporosis. They interfere with calcium absorption. They increase bone resorption. They suppress the cells responsible for building new bone. A single injection has a local and a systemic effect. With repeated injections, the cumulative impact on bone density is real. This matters enormously for the joint patient. If you already have osteoarthritis, your subchondral bone, the bone just beneath the cartilage, is already under stress. Adding a medication that accelerates bone loss to that environment is not neutral. And for those who are already osteopenic or osteoporotic, this is not a small consideration. This is a significant one. Steroids cause hyperglycemia. In patients without diabetes, this is often a temporary and manageable spike. But in those who are insulin dependent, in brittle diabetics, in anyone whose glucose regulation is already compromised, a corticosteroid injection can trigger a prolonged and dangerous elevation in blood sugar. This is not a rare side effect. It is a predictable pharmacologic effect of the drug. And it matters for healing because elevated glucose impairs the cellular environment that tissue repair depends upon. So you're taking a medication to reduce inflammation in a joint, but you're simultaneously creating a systemic metabolic state that works against recovery. And this is what happened to my patient. Cortisone is a synthetic glucocorticoid. Your adrenal glands produce cortisol naturally. And when you introduce a synthetic version from the outside, your hypothalamic pituitary adrenal axis reads that signal and reduces its own output. For most patients, this is transient, but for some, depending on the dose, the frequency, the individual sensitivity, and other medications, the suppression is significant and prolonged. Your body loses its ability to mount a normal cortisol response to stress. That affects energy, immune function, healing capacity, and regulation of inflammation throughout the body. And if you're at that suppressed state and something else happens, an illness, a procedure, an injury, your system can't respond the way it needs to. Less discussed, but worth knowing. Repeated corticosteroid injections enter into the soft tissue, can cause local atrophy or thinning of the skin, loss of the subcutaneous fat, changes in the surrounding tissue architecture. That's why you're typically advised not to inject certain areas too frequently or too superficially. It's also why the tissue environment around a repeatedly injected joint is not the same as it was before treatment began. Here's where I need to be very direct. If you've had a recent corticosteroid injection and you come to see me, I cannot use your own biology immediately. Regenerative approaches, whether that's PRP, bone marrow concentrate, or anything else in this category, they work by harnessing your body's own healing response. They're asking your biology to show up. And if your biology is being suppressed, it can't show up the way it needs to. So we go through a washout period, and we do not wait passively. During that window, there's meaningful work to do. Anti-inflammatory nutrition, correcting metabolic imbalances, addressing lab findings that affect healing capacity, high-intensity laser therapy to manage pain without suppressing the system, joint stabilization work, building the conditions so that when we do use your cells, the environment's actually ready to receive them. It's not a delay, it's preparation. I do not use corticosteroids in my practice, not as a bridge, not as a short-term measure, not as a compromise. It's a deliberate clinical decision based on everything I just walked you through. If cortisone is what someone is looking for, there are plenty of insurance-based practices that will provide it. This is not a criticism of those patients. It's just not what we do here. What we do is work with your body, your biology. We identify what's driving the problem, we optimize the environment, and we use tools that ask your body to repair rather than suppress. That requires more evaluation, more preparation, more patience in some cases. But the outcomes we're working towards are durable ones, not 2.5-month window before the next injection. So before you agree to a corticosteroid injection, ask one question. Is this treating the problem or is this treating the symptom? If the honest answer is it's managing pain while the underlying tissue continues, the issue is going on while your cartilage continues to degrade, while your bone density continues to be affected, while your tendon integrity is at risk, then you deserve to know that. And you deserve to know what it may cost your future candidacy for approaches that ask your biology to actually repair something rather than simply suppress it. You are not anti-cortisone for asking. You are looking out for your joint or spine for the long run. If you ask the right questions and pursue care that works with your biology, you preserve cartilage rather than accelerate its breakdown. You protect tendon integrity rather than quietly compromise it. You maintain bone density rather than contributing to its loss. And you keep options open rather than closing them. If you default to repeated cortisone without asking these questions, you may get short-term relief while the joint continues to deteriorate underneath it. You may find that each injection gives less and less return than the last, which is a documented pattern. You may arrive at a regenerative consultation with a washout period and a more compromised biological environment than you started with. And in some cases, a tendon or a bone pay a price that nobody warned you about. For some people, understanding this is enough to start making better decisions. For others, they want structure, sequencing, and accountability. If that's you, there are 2 ways I work with people. A guided system designed to help you start improving knee pain or shoulder pain or hip pain step by step, or a more intensive, personalized approach where we work together more closely. These options are in the description if and when you're ready. I've also put together a free resource called The Patient Guide to Ethical Regenerative Medicine if you want a clearer framework before making any decisions. And if not, keep learning. That's always a good next step.